recommend it to somebody that other people are interested.
Yep. I'm just kind of waiting to make sure everybody's here that's going to be here. If you guys have any problems hearing me, seeing anything, if there's any questions along the way, feel free to just stop me. There's a lot of slides here. A lot of the slides, to be honest with you, are they're just photographs and things like that. The perspective from this is going to be a little bit different. It's from more like an ATLS perspective, so a little surgical, medical perspective, so you guys can see what happens to these patients after they make it to the hospital, and do they make it, do they not make it? If they don't make it, what often happens to these patients, and why do they die? And that may affect your decisions as far as how to manage them in the field, where they should go. A lot of this has to do with more managing patients as far as where is the appropriate place for them to go and why and what to look for to try to make those decisions and whatnot. All right. So again, kind of like I mentioned, this is not really going to be a protocol review at all. It's going to be more like just a process of how to think, how to direct care, try to make decisions in the field and things like that. I think we got some fantastic medics here. I enjoy working with everybody, and I just want our entire crew to be the absolute best that they can possibly be. And of course, we always want the best for our patients and things like that. The other thing that's a problem for us here is we're in kind of a really difficult spot here because probably inside of Reese or Finksburg, it's probably almost always going to be quicker to go ahead and transport those patients by driving them down. And probably somewhere outside maybe Pleasant Valley area or something like that, it's going to be probably quicker to take those patients by air if they're serious enough. So we're kind of in that little zone between them where we have to make decisions, and it's often in flux. It depends on the weather, the traffic, how unstable the patient might be, and things like that. And it's a tough decision because a lot of times you guys are forced to make a decision about transporting a patient that may seem unstable or that you're worried about something happening in the back of the vehicle. But once that decision's made, it has a great consequence on the patient's overall endpoint, I guess, down the road. So those decisions are very important to be made in the field, and like I mentioned, once they're made, it's kind of hard to change things sometimes. And I'll get into exactly what I mean by that. So these are just kind of the outline of what we're going to do. I'm going to talk a little bit about radio consults and the decision tree, abdominal trauma. I've got a lot of anatomy pictures and things like that we don't have to go into specifics, but it's just interesting to kind of see. Some injury patterns, some couple of cases, go into some chest trauma also, again with the anatomy, some patterns of injury. We're going to talk about the 6 rapidly fatal injuries. A lot of chest trauma actually dies at the scene, but then 4 potentially fatal injuries that seem to affect patients more down the road. And it's actually interesting, the majority of chest trauma patients actually die after they make it to the hospital. Then there's a couple of cases for those, and then some musculoskeletal trauma with just some interesting information and some pictures and things like that. So as far as the consults and the transportations, it's important to be probably efficient to the point. I find when I'm working in the emergency department, after about 15 seconds, believe it or not, my mind's already thinking about the CAT scan I got on the patient room 1 and the code that I heard that's supposed to be coming in, and the pediatric patient that's screaming down the hallway and things like that. So not that the consult has to be 15 seconds, but you got to really kind of catch our attention in that 15 seconds. And the best thing to do is probably tell us just very briefly the specifics and what your concerns are. So this is a rollover accident. There's a significant amount of damage. The patient has an unstable chest, unstable vital signs. Believe me, you'll get our attention right away, and then the rest of it can go, longer than that without a doubt. And if we have any questions, we can certainly ask from that point. The one probably most important thing I want you guys to get from this lecture is that you guys actually control the majority of the decisions based on for these patients, where they go and how they're transported. And that really has to do with how you describe the patient. So almost any patient can be made to sound like they just tripped and bumped their head in the front yard on some grass or something like that. And almost any patient can be made to sound like it's some significant Category C trauma or something along that line. So really what you need to do is, look at the patient, see what your concerns are, and then probably step back for a minute and really kind of think about how you want to present that. Think about where you think the patient's best off, and then paint that picture that way. This was a rollover car accident, but the patient's out walking around, he's eating a hamburger, he looks fantastic, his vital signs are stable. Versus, although this patient just tripped and fell down the stairs, he can't move his legs, and he seems to have an obvious deformity in his spine or something like that. So it's how you paint the picture on those patients is probably the most important thing. And it doesn't really matter the format. In medicine, we often use the SOAP type format. I think you guys are probably familiar with it too. And you just describe it, the subjective as far as what happened, like belted driver and a rollover MVC. The objective, you just get the major vital signs, the GCS, any significant findings on examination, and then your assessment. What you think about this patient. He's intoxicated, but you're concerned that he may have some kind of intra-abdominal injury because he's a little bit hypotensive and tachycardic and things like that. And then what your final decision is, if you can make that decision and tell them what you want to do. I'm not going to say it doesn't happen, but for the most part, if you present a case and say, I think this patient's unstable, he may have bleeding in the abdomen, and I think he needs to go to shock trauma center, it's very unlikely they're going to turn that down. So, and if they do turn it down, you did the best that you can do, and it's off your hands at that point. So, and also, if you guys have a particular request, state it clearly. Sometimes we hear a very long presentation about a patient, and then at the end we're not really sure if it's just for information only or if you actually want something. So if there's something you want, like you want to give morphine, or you want to splint something, or you want to move or strap somebody down, whatever. I mean, just consult us and ask for any particulars about that patient. So probably, the thing that influences this the most, and I know you guys have heard it, but I kind of want to lay it out there so it's a little more clear, is the turnaround time for the local ED versus a trauma center. Once the decision's made to go locally, it's going to cost about 4 hours in time if that patient ever needs to be transferred. And the reason why is you're transporting them to Carroll Hospital Center, which can be anywhere from a couple of minutes to maybe 30 minutes or something like that. And then before we can order anything, they need to be registered. Then we get the labs, we get the x-rays. We have to wait for those to come back because, even though everything's stat at our hospital, it probably takes a little bit longer than it does at shock trauma or something like that. And we have to have all that information before we even talk to the trauma attending. Because we can't really call down there and say, I've got a patient, he looks kind of sick, he was in a car accident. They'll never accept the patient. I mean, they want a diagnosis. The patient's got a spleen laceration, he's dropped his crit, he's got a bleed in his head or something like that. So we have to actually have at least a significant amount of those results back before we can do anything. So then the process is we call shock trauma, we talk to Express Care, they page the surgeon eventually calls back if they're not in the OR, we discuss the case, hopefully they accept the patient. If they do, they try to search for a bed. If not, we start over with Hopkins or something like that, or Sinai. And then finally when all that's done, we've got to get a transport team out there and back. So, and you can kind of see 4 hours is actually pretty good. I think the fastest I've ever seen is maybe 3 hours or something like that. And the reasons why Carroll and local hospitals often can't handle these things is, first of all, we don't have any in-staff surgeons and OR staff all the time. We have some that are on call, but in general it takes at least an hour to get things taken care of. We don't really have a surgical ICU, which is a little more specialized than just an ICU, and we don't always have all the specialties available. So when you start talking about multi-system trauma with abdominal trauma, thoracic trauma, neurotrauma, maybe some extremities and things, it's hard to put all those specialists together at Carroll. And then there's some equipment that there's even some particular equipment that we don't have that is available at the larger trauma centers. All right, so the benefits of the specialty care centers is, again, they accept the patient directly. So you get the patient down there, they roll right in, they're registered, they're accepted. I mean, they can't really turn the patient down or anything like that. They've got immediate access to CTs, MRIs, angios. They've got specialists in all the fields. And then like we talked about, it is a difficult decision about, do you want to transport the patient, or are you afraid of them dying in the back of the vehicle, versus what's the best decision for them. And it is very difficult, but like I mentioned, once that decision's made, we can't often change things, and it can mean as much as multiple hour turnaround for that patient to get to the OR. This is just something I found off the net a long time ago. I always thought it was kind of interesting. So this is the trauma decision tree. Whether you like it or not. I mean, we can kind of use it to our benefits at times. Other times it makes things a little difficult. Probably the Charlie category is one of the ones that we use the most. The Charlie and the Delta. The Delta being EMS provider judgment. So anything that you feel, even if they don't meet the other categories, you think this patient may potentially become unstable, or you think there's any significant chest or abdomen trauma or anything else, you can make them kind of a Delta trauma. And I'm not going to go through all the stuff in here. It's just interesting to see the differences in the vital signs for the first two categories mostly, the GCS scores, some of the different things like amputations of limbs, and then the high-risk auto crashes. So we often see some of that with the falls of greater height. And then at the bottom, it gets a little more vague. And I don't see this often enforced at the age of less than 5 or greater than 55 and things like that. So again, a lot of it's provider judgment. It's how you paint the picture in the field. So we'll go ahead and we'll hit the particular trauma areas. And like I said, if there's anything you guys have any questions on, let me know. I'll probably move through some of the pictures pretty quickly, but if you want me to stop any of the slides with the anatomy or anything, let me know. Basically, a very large percentage of abdominal trauma, probably about 3/4, is due to blunt trauma. The peak incidence, unfortunately, is in young, healthy people. So most of these, as you can imagine, are probably new drivers, people that may be out drinking, things like that. So unfortunately, we have a lot of people with injuries that are otherwise young and healthy. About 80% of these or so involve some kind of vehicle accident, so it's not as much other types of injuries. We see some tractor-related injuries, some rollovers and things like that, and then also some livestock injuries like horse kicks and bulls and things like that out here, which is probably not seen too much downtown. And trauma is the #1 cause of death in young patients less than 35. This is just some of the anatomy. You can see up in the upper abdomen, the liver takes up a very substantial amount of the body cavity. The spleen takes up a little bit, but you can see it's actually protected. The big risk to spleen is probably with rib fractures and whatnot. This guy probably had a Big Mac or something in here. You can see there's a whole bunch of stuff still in his stomach. And then you've got the spine and the inferior vena cava down in here. When you go down a little farther, you can see that the liver starts tailing off. The kidneys pop up around here on both sides, and you've got the pancreas kind of coming across. And it's fairly well protected, but you can get some compression against the spine and things with blunt trauma. And as you get lower, you've got the colon sweeping across and coming down on both sides, and the small bowels mostly in the center. And then when you get down to the pelvis, you can see that you've got the rectum, the bladder, the prostate. In this case, it's a male, obviously. And the bones are in such close proximity, if you have any kind of pelvic fractures and things, it's very easy to damage any of those organs. So the basic patterns for this kind of injury is the pattern's often very diffuse and involves multiple organs, and it's usually due to kind of pressure exerted on the abdominal wall. And usually due to a sudden increase in pressure. So again, it can be if you strike it against either the steering wheel or a different part of the vehicle, or if the lap belt's not worn correctly, things like that. You can also have compression against the thoracic cage and the vertebrae. And the deceleration injuries are often where you have shearing forces. So, the car stops very abruptly and the organs keep going forward, but part of the body is actually held back by the restraints and things like that, so you can actually get tearing of the aorta, tearing of the mesenteric arteries and things like that, or tearing of the kidneys from basically their vascular pedicles. So the initial assessment, as we're all aware, airway, breathing, circulation. I know they kind of changed all that stuff around too. And then the secondary surveys where you start actually looking into the abdomen on these patients. So you start looking on the outside for anything, bruising, abrasions, laceration, bleeding. Evisceration is going to be pretty obvious. If the belly's distended, sometimes it's hard to tell if these patients are just a little bit on the large side or if they're actually distended. It's probably not really possible to listen for bowel sounds and things that much in the situation you guys are in. One of the most significant things is the seatbelt sign. So if there's a seatbelt sign, it's actually an 8-fold increase in the probability of abdominal trauma. So, and a little hint too, a lot of things I put in yellow is something that's important that may appear on the test and things like that. So, but that's actually really significant because we see a lot of seatbelt injuries, and that's something you guys really need to consider where that patient's going to go. That should at least, if not make a decision for you, it should really stop you to think about what's going on in that patient. And then you can try to palpate the abdomen itself. You can feel the lower ribs, the abdominal wall. You search for any kind of deeper tenderness or anything. If there's any pain on palpation, that patient's almost definitely going to require at least a CAT scan, if not a surgeon. So not that that would necessarily require a transfer down to a trauma center, but it at least is something just to think about. This is a very significant seatbelt injury. You can see where it involves both the chest and the abdomen and whatnot. So I don't think this patient would give anybody a second look. I'm sure that they'd be transported downtown, but it just kind of gives a little further insight into injuries and things like that. So with abdominal trauma, the presentations can often be subtle. So what happens is you get a little bit of bleeding going on or a bowel contusion or something like that, and they often look pretty stable at first, and then they start decompensating down the road. So the questions you need to ask yourself prior on the scene is, does the patient have any external evidence of injury or any tenderness, like the seatbelt sign and things like that? Are they unstable in any way? Because if they're unstable, that is really something that you need to kind of grab onto early, because if they're unstable that early, there's probably a big problem, and they're going to just get worse. And probably the main thought that you have at that point is the patient hemorrhaging into the belly. The injuries to the bowel and hollow organs like that tend to be things that turn up 12 hours down the road. It's more like an infectious type picture where they get peritonitis and things like that. So probably the big thing is if there's evidence of abdominal trauma and there's hypotension, they probably should go directly to a trauma center. And this is just a little bit about the incidence of organ injuries. You can see the solid organs are probably the most easily injured, so the spleen, the liver, and the kidney. It's actually interesting that the spleen is that much higher than the liver, considering the liver takes up so much space, but that just seems to be the percentages. The small bowel and the colon take up a much lesser percentage, and then the retroperitoneum, which is where some of the other structures, in fact, the kidney even is back there, and then the diaphragm also is back there. And this is just an obvious example of an evisceration after a car accident. Some of these things are real cases that I'm going to be presenting. Some of them are just things I found on the web. This was, I think, one I found on the internet. All right, so case one. It's a 19-year-old male belted driver. He falls asleep while driving home from college and strikes a barricade at high speed. There's a prolonged extrication on this patient. And then this is what you kind of see on the scene. So he's got a seatbelt sign on his right upper quadrant. And this is what the initial evaluation shows. So he's got complaints of pain to his hip, his chest, his abdomen, everything on the right-hand side. He's a little tachycardic. His pressure's kind of borderline. Respiratory rate's a little high. Again, he's got a lot of tenderness on the right-hand side. He's got the seatbelt sign. Otherwise, he's neurologically intact, and his extremities don't show any problems at all. So I guess the first question is, what is the patient's trauma category, and then where should this patient go and how? What's that? Sure. Okay. And what do you think their category is?
Sick. Currently sick.
Right. And should they go? So I'm kind of hearing probably a C, and that they should definitely go to a trauma center. How do you think they should go?
Where are you at?
Let's say this happens at right Pleasant Valley Road because there's no light there.
A lot depends on the helicopter coming. Depending if they're tied up somewhere else, you're going to end up driving anyway.
You also mentioned you have a prolonged extrication, so if you get a good assessment quickly on this patient, then, I mean, you're talking 20, 30 minutes for extrication time, so the helicopter going to be on the ground, and you're going to save a lot of valuable time that way.
Right. And that's true if they're available and you get some things that you're concerned about, the patient's still in the car, you can call them early and things like that. And I'll be honest with you, you guys will have a lot more experience in that kind of decisions in the field than I do. I showed up at a trauma once, and it happened to be at Pleasant Valley, and I felt like a fish out of water. I mean, without my order pads and nurses to get the medicines and things, I really have a lot of respect for what you guys do. I mean, it's really difficult, I think, to assess these people, and there's a lot going on that I never knew until I actually showed up. So I give you guys a lot of credit for all that stuff. All right, so this is basically the decision tree, just to kind of look at it in case anybody had any questions. It probably, and I agree, it's probably a Charlie would be the best way to do it by mechanism and whatnot, because he doesn't quite meet the GCS, and his vital signs actually don't meet the vital sign category either. And then this is basically, why he met the Charlie, trauma, and then error, again, probably a greater than 30 minutes, and that would depend on some of the other things that we talked about. All right, so about 30 minutes later at Shock Trauma Center, his heart rate goes up to 160, his blood pressure drops even more, he's a little bit hypoxic, but not too bad. You get a report and clean your shorts, and basically this guy's life was saved because he was taken directly to a trauma center. So this is basically a follow-up on that patient. He had a liver laceration with some active bleeding, a contusion of the right kidney, a small bowel contusion where a section was actually devascularized, so it was basically kind of dying and necrotic. They were repaired in the OR, and then he was discharged after a couple of weeks after a prolonged SICU stay, so he kind of probably ran into a bit of ARDS and whatnot in the unit. These are just some gross surgical specimens. You can see the liver laceration in here, small bowel contusion with basically dead, kind of necrotic looking bowel over here. And this is what the CAT scan looks like on these patients. So this is actually just a grade 2, so just a small area of laceration, and a grade 3 over here where you actually have disruption of a significant amount of the liver, taking up about half of it or something like that. And this is a huge liver laceration. So this is basically through the majority of the liver, involves a lot of the vessels and things, and obviously this patient's going to bleed like stink. In fact, in the OR, what they often have to do in these patients when they're unstable is they literally do a laparotomy, so they open them up and they just grab a bunch of gauze and they just pack these off, and then they close them right back up, send them to the SICU, and their only goal is just to stop the bleeding at that point, and then they have to actually go in and try to repair this like a day or two later or something like that. All right, so case number 2. It's a 28-year-old woman. She's an unbelted driver on a city street. She turns around to check on the baby in the backseat and strikes a car that was stopped in front of her. She didn't lose consciousness. There's no head injury or anything like that. There's probably a moderate amount of damage to the front of the car. And she complains of pain up in her left upper quadrant, left chest, and she thinks she hit the steering wheel over there, and she feels a little short of breath. So her vital signs are relatively okay. Her blood pressure is a little borderline, but her SATs and heart rate are okay. Respiratory rate's a little high. It's always difficult, especially after seeing the patients are upset and often in pain, so it's always hard to know what to make out of things like the heart rate and the respiratory rate. And on the chest, you see some tenderness and bruising at the left lower ribs, a little decreased breath sounds at the left base, and some tenderness in her abdomen, and otherwise she's okay. Extremities and GCS look fine. So what's this patient's trauma category? And then are there any additional concerns that wouldn't be addressed by the category?
Did you say the speed?
I didn't, but it was kind of in the city, so probably 25 miles an hour or something like that.
Would be a D in my opinion. I mean, if you had to give it a category.
Yeah, you could either make it a D, or based on everything else, she could actually just be a.
The decreased breath sounds could mean that you're looking at some sort of a potentially evolving. She's short of breath. She's got 95 stats. She's got respirations of 28. She did it pretty good. She was turned to take with one force, and she was turned around for the baby.
Right, that's kind of what my thoughts are too. I mean, she could, by vital signs alone, really make no criteria and just be treated as a trauma, but not any of the, the alpha through delta criteria. Or she could be made a delta just by mechanism and concern, like Susan's saying. So again, this is just kind of like the tree, just to see if there's any questions or anything. So the provider here, and again, this is kind of a hypothetical case, did not make him a category. They said, okay, he's stable. There's a little bit of chest injury. There's some tenderness, maybe a little decreased breath sounds, but otherwise they're pretty stable. And the patient had a little bit of an elevated respiratory rate and borderline vital signs, and that's what we talked about. You could have been made a delta or something like that. So they were transported ground to a local ED. And the studies at that time at the ED revealed a splenic laceration with hematoma, a tear in the left diaphragm where the stomach actually kind of rode up into the patient's chest, which is what the decreased breath sounds were at that side. And they were transferred to a trauma center after about 5 hours stay in the ED. So the patient remained stable. There probably wasn't any significant bleeding at all, but they had enough injuries that it was going to require a trauma center to take care of. And then the lacerations and diaphragm were repaired at the trauma center, and they were discharged a few days later in relatively stable condition. And the main thing here is because there wasn't bleeding and hypotension that much, it was more just like a surgical repair just to correct the injuries. And these are some of the pictures. This is the splenic laceration here. And this one's a little hard to see, but that's a hole in the diaphragm. And what happens is the stomach can actually ride up into that, and I'll show you some other pictures of that. But if that's missed and not repaired, which can often happen because a CAT scan won't show it unless there's actual herniation of the stomach and things like that, these things eventually will rip, and the patient will end up, with pretty sick. Like it can be anywhere from months to years down the road. So diaphragmatic ruptures can occur on either side. It's more common on the left because the liver protects the right pretty significantly. And it's usually caused by significant rise in pressure. So lap belt being across the belly or striking something with the belly would be the main causes. This is what they kind of look like. So on an X-ray, you'll see, this is going to work too much more, but anyway, you'll see the stomach up inside the chest cavity here, and this is all just collapsed lung. So you kind of hear about atelectasis and things, that's collapsed lung. And then kind of the same thing here, you can see where the stomach actually kind of comes up inside the chest cavity over there. And this is what it looks like with a barium swallow. And you can see this is probably where the tear is, and everything on top is in the chest, and everything at the bottom is still in the abdomen. And then these are some pictures of some splenic lacerations. So you can see the laceration here, and this is basically just a shattered spleen. So in these cases, the patient often just completely gets a complete splenectomy. They remove the whole thing. These, a lot of times they will, depending on how much bleeding, how stable they are, sometimes they'll actually watch these. The other choice is sometimes they'll do like a CT angiogram, and they'll actually try to put small coils in there to stop the bleeding. And this is just kind of an open picture of a splenic injury. All right. So this is more common in downtown than we see out here, but unfortunately we're beginning to see a lot more things like this and some shootings and whatnot that, I don't think we saw so much in the past. So approximately 25% of the trauma deaths are due to thoracic trauma. And this is the one thing I found really interesting, is that the majority of the thoracic trauma deaths occur actually in the hospital. So they don't occur, in the field or in transport or anything like that. And what happens is, initially these patients are stable at the scene, and then they start deteriorating after they make it to the hospital. And it can be due to things like either ongoing bleeding or pulmonary contusions, cardiac contusions, and things like that. This is just basically the anatomy. So obviously the lungs take up a very significant amount of the chest cavity. And then you can see up here in the top part of the chest, you've got the ascending aorta and the superior vena cava coming down into the heart. And these are the bifurcation of the main bifurcation from the trachea into the right and left main stem bronchi. And then you go a little lower, you've got the right and left ventricles. And you got the esophagus is actually sitting, you can see it's actually between the heart and the descending aorta. And then these are just MRIs. And it's always fascinating to me, some of the images and stuff they can get with these things. All right, so with blunt trauma, a lot of what happens in thoracic injury is you have compression, and it causes rupture of the organs, whether it's the heart, the great vessels, or the lungs themselves. And direct trauma often causes fractures, which can lead to penetration of the lungs and things like that with pneumothoraxes. And then the shear forces are due to the acceleration and deceleration. So you can often shear the aorta either at the top of the heart or where the ligament actually comes across. And those generally tend to be rapidly fatal in the field. So those patients you often get there and they're basically dead on the scene. And for penetrating trauma, as you can imagine, because the lungs are so big, nearly 100% result in pneumothorax. That's something you always have to keep in mind. And the vast majority of them, about 3/4, result in a hemothorax, and about 30% are associated with abdominal injury. So it's kind of interesting when a patient breathes, if they exhale all the way, their diaphragm can actually come up to about their nipple level or something like that, so about the 5th intercostal space. And if they take a very deep breath in, they can actually go down to, I think, something like the 9th intercostal space or something like that. So I mean, it's really pretty big and significant. And you often don't know what position they were in when an accident occurred, whether it was blunt or penetrating. And these are the primary survey. These are things you want to kind of recognize right away. So these are the rapidly fatal injuries. So airway obstruction would probably be picked up, very quickly. Tension pneumothorax can be, but it's a little difficult, especially with a lot of noise at the scene. An open pneumothorax, a flail chest, cardiac tamponade, which would basically result in a patient that may be in PEA or very, very hypotensive. And then massive hemothorax, where, again, they would be hypotensive and you may not hear any significant breath sounds. So one big thing to tell the difference between a tension pneumothorax and a hemothorax is you're listening to breath sounds, you're not hearing anything. So you can actually tap on it. And if you hear, if it sounds very, very hollow, like an empty can, it's possibly tension pneumothorax. And if it sounds very, very dull, like it's full of liquid or something, there's a chance there's a lot of blood in there. So that's just something to kind of keep in mind there. All right, so with airway obstruction,
Can you back one slide?
sure.
Thanks.
Okay. All right, with airway obstruction, often happens with trauma to the head and neck. So, people that may have tried to kill themselves or something with a shot to the head, or the head hits the windshield, things like that. You often see so much swelling and whatnot that you can lose the upper airway. If they have altered mental status, they might not be protecting their airway. You can have blood or foreign bodies or vomit in the airway. You can have tracheal disruption or hematoma somewhere in the neck. The signs are often, you'll hear stridor, they'll be hypoxic. You may see a lot of retractions where they're trying to make the respiratory effort, but it's not going anywhere. It's almost like when you see a kid with croup and they just can't move anything. And usually the best treatment for these patients is to intubate the patient because, unless it's something simple to clear out of the airway, they're going to deteriorate pretty rapidly. The one thing you want to keep in mind, though, when you intubate them is usually in a face-injured patient, you don't want to do an nasotracheal intubation because you can end up in a bad position, which I have a slide of at the end, and you usually want to do oral. And with a tension pneumothorax, basically what happens here is you develop a small hole in the lung that kind of forms almost like a one-way valve, and the air goes outside of the lung when you try to breathe. So you move your diaphragm down to basically fill the chest up with air. The air goes outside of the lung and goes into the potential space between the lung and the thoracic cavity and just pushes the lung completely across. And as that tension and pressure builds up, it can actually collapse the lung entirely, can shift the mediastinum, and sometimes can even collapse part of the other lung. And again, the signs are absence of breath sounds on that side. You can have some deviation. Usually they're in a lot of respiratory distress. And if you tap on the chest, like I mentioned, a lot of times they sound very hollow. And this is basically what a pneumothorax looks like. So you can see on this side over here, This is basically just all air. This is collapsed lung that just basically kind of collapsed up against the heart border. This is what it should look like with, you see a lot of like blood vessels and things like that over here. And on a CAT scan, this is kind of what it looks like. Again, you got, all air here. It's actually pushing the heart over this way and collapsing that lung a little bit too. And usually the treatment for this, I don't know how many of you guys have done that. I know it's in the protocols, but doing a needle decompression in the field. I don't think very many have done it. I think I've seen one patient come in, one or two patients come in, but it's not very often. And I think part of the difficulty you guys run into is, again, it's really hard to hear things in the field, so it's hard to make that decision. And where you typically will tend to go is between the second and third intercostal spaces, usually like kind of mid-clavicular line, so kind of right in there. And the other thing worth mentioning, because I don't know if this is something they cover that much in the EMS type training courses, but the nerves and the arteries and the veins run on the underside of the rib. So what I generally do, okay, yep, I kind of walk off the front of the top part and go in that way. That's usually the best thing to do. All right. And then an open pneumothorax, which is otherwise known as a sucking chest wound. Usually it's a pretty big defect in the chest wall, and it's got to be about 2/3 the diameter of the trachea to actually cause that. And then what happens is preferentially air will move in through that wound, and it won't go through the trachea. So you have a pneumothorax on that side, but it's not necessarily a tension pneumothorax. But the air, when you try to breathe, is basically just going in and out of that hole, and it's not going into the lungs to the trachea, so it's basically not doing anything. And the treatment for these type patients is you basically have to intubate them, because if you don't intubate them, you're just not going to be able to move air through the lungs. It's just going to keep going the other way. And when you cover the wound, you just have to put occlusive dressing on 3 sides of the wound so it doesn't turn into a tension pneumothorax. And then flail chest is just multiple rib fractures. So you've got a series of rib fractures, but in 2 or more spots. So that section of the chest is actually kind of free and it moves independently. So when the patient tries to breathe, what's happening is the chest tries to expand out to fill the lungs, but that section of the lungs is actually kind of collapsing back in. So you're not effectively moving air. But probably the more significant thing with this is if you've got a flailed chest, I mean, you really had significant trauma to your chest. So the bigger issue is probably going to be pulmonary contusion underneath if they don't have a pneumothorax of some sort. And the signs for a flailed chest, you can have some air underneath the tissue. Again, like I mentioned, the paradoxical chest wall motion. And the biggest thing is just treating the underlying pulmonary contusion. So pain control, oxygen. If they really are still not doing well, they may need to be intubated. And this is what basically an older patient with a flailed chest looks like. And you can just see, the significant amount of pulmonary contusion in here. It's all just a lot of edema in the lungs. This is the kind of like popcorn-looking stuff on the outside here is just the air inside the tissue and things like that. All right. And then cardiac tamponade occurs more frequently with penetrating trauma. And basically what happens is the heart's surrounded by the pericardium, which is almost like it's almost like a fiberglass sheath, basically. So it's a little flexible, but it doesn't expand very much. So what can happen is, in a healthy patient, even 50 cc's that gets in that space can basically collapse the heart, so it doesn't work very effectively. Sometimes in older patients, you can have as much as 100, 150 cc's of fluid or blood or something like that in there. That generally occurs over a long period of time. So in like patients with renal failure and uremia, they can develop like some fluid in there. But that develops over such a period of time that heart compensates, the pericardium stretches a little bit. So that won't have that effect. But in a young, healthy person, 50 cc's can do it. And it can be blood from a ruptured chamber. The vessels can rupture themselves. The aortic root can basically tear and can fill it up. And then, like I mentioned, it just inhibits the filling, which inhibits the output. And then you basically end up in a situation where the patient is very hypotensive and shocky. Beck's triad is kind of a thing everybody kind of knows about. It's just one of those kind of words. I think it's something that's very difficult to see. The hypotension certainly you can see, but when you start listening for muffled heart sounds and venous distension and things like that, I mean, those patients are pretty far along, and again, it's probably pretty difficult to hear on the scene and whatnot. And these patients often will come in PEA, so basically their electrical activities there, the heart's trying to move, but it's just absolutely ineffective. This is an antenna wound to the chest. You can see where it actually punctured the pericardium here. This is a knife wound to the chest with a fairly enlarged heart. And we actually had a case when I was in Bayview working in the emergency department at the time. The lady came in, she was probably about 30-ish or something like that. Said she had just been stabbed in the chest. She ran into the apartment, collapsed on the floor when she got there. We took her in the back, gave her some fluids, and miraculously she came back around with some oxygen and fluids, and then she collapsed again and became hypotensive. And they actually, the surgeons came down, cracked her chest right here in the ED, and they found that she actually had a penetration of her right ventricle, and blood was leaking out, filling the pericardium. So what they did is they basically opened the pericardium, put a catheter in, expanded the catheter balloon, and basically sealed the heart up that way, and rushed her off to surgery, saved her life, and then proceeded to have 2 of the most miserable weeks that surgical team had ever had, because she was apparently a not terribly pleasant patient, let's just put it that way. So it was an interesting case from that perspective, but I don't know, you never know with these patients, but I guess we can't make that kind of decision. And then massive hemothorax, we see it more often with penetrating injuries. And the definition, which isn't something that appears on tests or anything, is just over 1,500 cc's of blood in the thorax. And usually these patients, what you see is just hypotension and shock just from the lack of blood is the majority of it. That's probably a bigger issue than the compression of the lung. And this is what it looks like. You can just see there's a lot of blood. There's actually an air fluid level here. This patient was laying down, so you can actually see where the blood just kind of filled that whole chest cavity. And then PEA, can be multiple causes of PEA. You can have tamponade, like we mentioned, the tension pneumothorax, blood loss, hypoxia, acidosis. And the most important thing with trauma in PEA is you have to treat the underlying cause. So you can do CPR. In fact, I'm sure that you'll try CPR, but in general, the CPR is not terribly effective, and the drugs are generally not effective either. So if you're trying to give epinephrine, atropine, and things like that, it's just not going to do anything because the heart's basically, it can't get the blood to it in most cases. So you can give epinephrine all you want. The heart may actually beat faster, but there's nothing you can do. So you have to volume resuscitate them. You may have to do a needle decompression. I mean, whatever's the cause has to be fixed. And if it's an issue with potassium or hypoxia and things like that, sometimes there's nothing that can be done until they get to the ED or something like that. But these patients often, may be helped a little bit by bicarb also because it'll help some of the acidosis. So these are some potentially fatal thoracic injuries. Probably one of the biggest ones is pulmonary contusion. And like I said, these patients often, look relatively good except for some bruising, but they just start getting more and more hypoxic slowly over the course of some hours. Traumatic ruptures, and we'll get into these when we get to slides, but they often die in the field. Injuries to tracheobronchial tree, and then myocardial contusion, which can also be a pretty significant injury, which reveals itself kind of later on down the road. So again, like I mentioned, the pulmonary contusion is probably the most common, potentially lethal thoracic injury, and just from blood leaking into the lung itself, and it becomes very ineffective at oxygenating the patient. And patient, you can give them oxygen, you can intubate them if they need to be in once they're in the hospital and whatnot, but you're basically just trying to compensate for the hypoxia, and it's not where the lung's bleeding in one particular spot where you can actually go in and surgically try to fix it. It's usually due to kind of vast damage to the lungs, so you're just trying to keep their head up above water long enough that that the patients can kind of heal themselves. And this is just kind of what it looks like. I mean, in a sense, it looks like kind of like what a pneumonia would look like, and then there's just some blood down the bottom here, and you can just see where it's very just kind of cloudy and looks almost like congestive heart failure. Then aortic disruption often occur from high-speed deceleration injuries or side impacts. And these patients usually have multiple rib fractures. And if you see a fracture of the first or second ribs or the scapula, so up pretty high, that takes a lot of force because those ribs they're pretty short. So it takes a lot of force to crack those ribs. So if you see that, at least keep in your mind, there might be something more significant inside. It's much easier to crack the lower ribs. And they talk about a little bit of the pulse deficits. Again, that's going to be a little hard to see in the field. If it ruptures, it's usually like sudden death. By the time you get to the patient, they're already gone. And if it tears, they say about 5% will die within the first 48 hours just due to completion of the rupture. So, once they hit the hospital, the big thing is the centers have to actually think about that because you have to get a CAT scan of the chest to actually evaluate for a possible disruption. If it's just a chest x-ray, it may not show up at all, and the patient may actually finish tearing later. That's one of the good things, too, about like a place like shock trauma. Those patients get in there, and they kind of pretty much scan them from head to probably pubis and try to get all that information right away. And then this is just a widened mediastinum, which is something that we see in the in the hospital. This is just a wide area here where the aorta is actually just kind of has ballooned down a little bit. I think this is the same thing. This just shows a tear at the kind of a disruption right there in the aorta, just where it starts descending down. And this is a really, really wide mediastinum. So this patient probably would not be very stable or anything in the field. And then injuries to the tree itself. So we're talking about basically the airways here. Very uncommon. Usually it's penetrating injuries. So gun blast or a knife wound or something like that would cause the airway itself to open up. And a lot of times they're spitting up blood. They can have a tension pneumothorax because the air leaks out and will compress the lungs on that side. And they often have a lot of subcutaneous air where it's all the way up into the neck and even into the, up by the jaw and things like that. And myocardial contusion, it's usually blunt injury to the anterior chest or sternum. It's just like a bruise to the leg. I mean, you can imagine you get a big kind of hematoma developing in there, and it can cause hypotension from the heart itself not functioning and beating correctly. And you can see a lot of different arrhythmias, so bundle branch blocks, ST changes, some widening of the QRS complex. Some of them can look a little bit like an MI, so it makes things kind of difficult sometimes. And it's often difficult to pry out were you having chest pain before the accident or after the accident, and try to keep that in a little bit of perspective. All right. So case one for the thoracic trauma. 43-year-old male belted driver in a front end MVC with a brick wall. Steering wheel was bent. Patient was initially awake and complaining of chest pain, but then became unresponsive. And he was intubated at the scene due to hypoxia and to protect his airway. And he was initially stable, but then during transport, the patient lost pressure and went into arrest. And these are what the vital signs were after the arrest. So his heart rate was very, very low and agonal. They weren't able to get any palpable blood pressure. He had some pretty significant bruising to the chest wall. His trachea was midline, but he had very poor air entry and no breath sounds on either side. And when they tapped on his chest, they could hear it sounded pretty hollow on both sides. All right, so which of the following is most likely to be the most effective on this patient?
I don't think it's
Right. So kind of like we talked about before, I mean, everybody's going to start CPR. It probably isn't going to help that much. The EPI certainly isn't going to do anything. The chest decompressions will do it. And the reason why in this case the trachea was still midline is because they're actually bilateral pneumothoraxes, so it wasn't pushed one way or the other. And he was basically in a PEA arrest because of that. And just like we talked about, you treat the tension pneumothorax. In this case, the patient had the bilateral, basically empty on both sides. And that was it. So there's no follow-up, but basically the guy was decompressed in the field and came back. So case two, a 52-year-old male roofing engineer fell about 3 stories onto grass, landing basically on his left side. And he was alert but in severe respiratory distress and severe pain. He was boarded, collared, and oxygen was being administered at the scene. And these are his vitals. So he was very tachypnic, and his oxygen stats were pretty low, even on 100% face mask. Otherwise, his trachea was midline. He had a little decreased movement on the left of the air movement. You could feel some rib fractures on that side with a little paradoxical chest wall movement, so a little bit of a flail chest. And otherwise, everything else looked relatively good. So the patient started to become a little confused, combative, and then became unresponsive. So what was the best thing to do with this patient?
He had pneumothorax. The key to the whole thing was shallow breathing, rapid shallow breathing. He could not take a deep breath. He was in a lot of pain due to his breathing.
Right. But it could have been, I guess what's the first thing that you would do with this patient?
Well, can you rapid transport?
Yes, I guess you could. But I think what they were trying to say by the rapid transport is not do anything except just kind of run. So, but yeah, I think in this case, probably the first thing to do would be to intubate the patient because he all of a sudden became unresponsive, and then at that point try to figure out what happened, because it could be a pneumothorax on that side, but it could just be severe pulmonary contusions on that side too.
If you intubate, the compliance will be noted on the intubation then. You'll notice compliance by the ventilations will be very hard. Obviously, it'll be a lung issue at that point.
Right. So I would probably try to intubate the patient first, and if the stats popped up and everything was okay, then that's great. And if not, then you definitely go straight to needle decompression. And this patient had the flail chest like we talked about. And the significant thing with these patients is usually the underlying pulmonary contusion, although they can certainly have pneumothorax. So, you take the patient and you intubate them to basically take away their pain and to breathe for them. But you also have to keep in mind that they might develop potential pneumothorax from that. So once the patient's intubated and you're giving them positive pressure, if there's any lung damage, they're gonna develop potential pneumothorax. Then you're gonna have to keep in mind about needle decompressing them down the road.
Question would be, with that particular patient you're going to intubate them, there's a little bit chance that once you're ventilating and they come back, you're going to have tube bucking. Would that be a particular patient that it would be appropriate to give them some sort of sedation? And that's not going to compromise anything else that's going on?
Probably the only thing you'd have to worry about would be the blood pressure or something like that. And
you would use Versed versus the morphine, or
you could probably use either one, and it would be fine. These type of patients, and it kind of depends what the vital signs are. If it was a relatively straightforward pulmonary contusion, their pressure is going to be fine. It's going to be more like hypoxia and pain type issue. So, all right. So we're going to go into a little bit of musculoskeletal trauma. This is going to be somewhat superficial. There's just some kind of major topics and stuff like that to hit. So again, you do the primary, then you do this as part of the secondary survey. You're looking at all the extremities. You're checking their neurovascular status, seeing if they got pulses, and just grossly are they intact. And you palpate for any kind of deformities, bruises, tenderness. And probably the best thing to do is on the scene, just try to mentally reconstruct what happened. Like look at the vehicle or wherever they were located, look at the patient, try to figure out what happened, to try to figure out, did they get their arm stuck in something and twist it where they might have fractured something, where they injected, was there a fall from a particular height or something like that. And for spinal trauma, about 90% of spinal cord injuries are due to blunt trauma, so the majority of those would be due to probably car accidents. And the C-spine injuries take up about 61% or so, and then it kind of goes down from there. So most patients in the field actually complain of low back pain. You can see it's like almost impossible to fracture a back. I mean, I'm not going to say impossible, but it's a very large set of bones, and it's very hard to injure down that way. And some interesting patterns are 15% of patients with injuries above the clavicles will have C-spine injuries, and 5% head-injured patients will have C-spine injuries. And this is the reason why when patients are involved in trauma and they're altered at all, we just board and collar like kind of right off the bat, because actually a pretty fair percentage will have some injuries and things like that. call this guy because I think he needed to switch over the. Hey, it's Mike. We're probably about an hour into the presentation. All right, thanks. So we're going to go on. We're actually getting pretty close to the end anyway. All right. So it's just the kind of normal anatomy and x-rays for the C-spine. And in general, this is what we've got. So the cord kind of lies like right in here. So this is the anterior column, and these are the posterior pedicles and things. The cord kind of like flies right back behind in that area in there. And the MRIs are pretty fascinating. Unfortunately, the technology isn't such that we can get them very easily nowadays. But that probably will be the way of the future. And this is a sagittal view of the C-spine. You can actually see where the cord lies in there. An atlas fracture, so C1 is called the atlas, and basically it's a ring. And when you have an atlas fracture, it's usually called a Jefferson's fracture. It's a burst fracture of C1, and it usually results from an axial load. So somebody diving into a pool. You want me to hold for a second?
If you could. Just give me 1 second. Actually, keep going. It's got some time left. Go ahead.
So it's usually an axial load. So somebody diving into a pool, diving into a creek, hitting their head on something, or something dropping and striking somebody on top of the head. It's a fairly low percentage of all spine fractures, but it's very unstable and needs to be recognized. And an odontoid process fracture is a fracture of actually C2, and the odontoid is the piece that sticks up inside of C1. It takes about 10% of all C-spine injuries, and it's basically where the odontoid process, which is part of C1, actually goes inside of C1. And again, that's very unstable. This one is actually, this guy certainly didn't do well, and I'm sure probably didn't live. But this is a complete dislocation of C1 on C2, so pretty rare. And these things, generally, when you talk about a C2 fracture, it's in the olden days it was called a hangman's fracture because they actually died by the snapping of the neck. But we see it more commonly nowadays in high-speed rear end MVCs, so where the neck kind of snaps back very quickly. That would be the majority of these. And a lot of times these patients, which I found kind of interesting, this was new to me too, the canal is a lot larger up in that area, so the patients may not have a tremendous amount of swelling or any neurological deficits initially, and you can move them and they can just have an injury cord that quickly. So it's very important, especially if there's any kind of high tenderness or pain, just to get them on a board and get them collared pretty quickly. All right. So pelvic fractures are pretty common, and especially for the population we see here, because we've got a lot of nursing homes and things like that. A fair amount of blunt trauma patients from car accidents and whatnot will have pelvic fractures, and they can they're actually very commonly associated with death. And the reason why is these patients will actually hemorrhage pretty significantly into the pelvis. There's a lot of blood vessels in there, and you can imagine it's extremely difficult to get in there to get anything to stop bleeding. In fact, they tried the mask trousers a while ago. There's still some thought maybe they can work to some extent, but in general, it's very, very difficult to control the bleeding of the pelvis. And you're trying to basically, if it's fractured and out of alignment at all, you're just trying to get it in alignment, just kind of camping on it by getting everything back together. But in general, these patients usually end up going to major trauma centers, and this is where they do that CT-guided embolization. So they'll put small pieces of basically metal coils in there to try to stop the bleeding, because it's nearly impossible to get in there and surgically correct these things. So let's see. And the other thing too, when I showed you the scans earlier of the abdomen, you can see how everything's really in close proximity with the pelvis. So when you fracture the pelvis, you can often have injuries to bladder, urethra, vagina, rectum, anything like that. So usually with these patients, any kind of hypotension, especially if they fail to respond to fluids, and there's any kind of significant pelvic injury and bruising and whatnot, it's something to keep in mind that there might be some significant bleeding going on in there. And this is just kind of some quick anatomy, and kind of like we went over before, you can see how everything's just in very close proximity to the pelvis down in this area. All right, so 2 or more breaks in the ring are unstable, and you don't need to know about this for a test, but there's 3 types of pelvic fractures based on the force. You can have lateral compression, which is apparently the most common, usually from like a side strike to a car or something like that. AP compression, and then vertical shear fractures, which are much less common. So lateral compression, again, accounts for about half, and it can often result in injuries to bladder and urethra, and the mortality is about 13%. And again, it's usually broadside MVCs or patient struck or something like that. And these are just examples of kind of where those fractures can occur. There's different classifications which aren't terribly important for us or anything. This was kind of interesting because this is the bladder here, and this is all dye that's leaked out around it. And what they do is they do what's called a retrograde urethrogram, where they actually put dye inside the urethra and it filled the bladder that way, and this actually leaked out outside of it because of an injury. And for the AP compression fracture, the first one resulted usually in more injuries to the organs, whereas this results in more significant hemorrhage and things like that. And usually it's a head-on MVC or motorcycle crash, something like that, or a pedestrian that's struck more or less from the front or from the back, or a crush type injury or fall. And again, these are just some different things here. You can see this is actually fractured here, which is similar to here. And this is just a lot of blood and things like that in the peritoneal cavity. And then for extremity trauma, I mean, there's a few things worth knowing about it, to be honest with you. Probably the compartment syndrome is one of the biggest things, which we'll just kind of touch on. But orthopedic injuries occur in a very significant amount of patients. So you may have head trauma, neck trauma, belly trauma, something like that, but there's often associated extremity trauma. So the best thing to do is examine the extremities. You look for wounds, deformities, swelling, things like that. You try to find any tenderness. And probably one of the most important things is to at least check for either pulses or capillary refill. Hip fractures we kind of talked on earlier. Part of the big problem we're having is because the population is aging as much as it is, it's becoming a bigger and bigger problem. With knee dislocations, one of the big things to worry about in particular with them is a popliteal artery injury. So a lot of times these patients will say, their knee felt like it went out and then all of a sudden kind of popped back into place or something like that. It's very important to check distal pulses on them. And from our perspective, what often happens is they may actually have a pretty good pulse in there, but there's a small dissection or something from the disruption. So oftentimes we have to either admit those patients and watch them or get some kind of like angiography to make sure that there's not a disruption. And with the tibial or tibia and fibular fractures, you have to worry a lot about compartment syndrome. That's probably one of the major things, and disruption of the nerves and arteries that go along with it. And this is pretty important with compartment syndrome. It results basically from an increase in pressure within that particular compartment. So you have bleeding either from a hemorrhage or from an actual laceration of a vessel or something, or just from edema building up. And again, just like the heart, the bundle of muscles basically surrounded by a very tough sheath that doesn't give very much. And what happens is when the pressure builds up in there, then it starts cutting off the circulation, and then it starts eventually causing problems with the nerves. And the locations for this is usually it's the lower leg first, and then the foot, and then the forearm, and then the hand. And it can be caused by any of these things that we talked about: hemorrhage. Reperfusion is more an issue, like when patients are taking the OR and may have like a AAA repair or something like that. But probably a lot of crush injuries and things like that would be things we'd see in the field. And the signs and symptoms are often pain, and then paresthesias, and then this is why they call it the 6 Ps, but basically loss of color or pallor, pressure which you can actually feel or tightness, and then paralysis and pulselessness which are late. So once you kind of get down to these bottom things, they're pretty far along. And this is what a fasciotomy looks like to try to relieve pressure in those in the compartments. And then I think this is the last one. So basilar skull fracture. This was actually just more like an interesting case. But the primary things you look for are like periorbital ecchymosis or raccoon eyes. You can see some bruising behind the ears, which is called battle signs. And you can sometimes see CSF actually leaking from either the nose or the ears and things like that. And it's important that if you see it, you don't nasally intubate them or place an NG tube, which would be more of a hospital thing. And why, you ask? This is actually an interesting photo I found. This is an NG tube that is wound up inside a patient's brain where somebody put an NG tube in and with an unrecognized basilar skull fracture. So kind of interesting. All right. So the basic summaries is, there's been a lot of talk about this golden hour. Is there really a golden hour? Is there not a golden hour? I don't know what the actual answer is, but I think there probably is a golden hour that patients would usually remain pretty stable if they're not immediately unstable in the field. And with that time, decisions have to be made, and if they end up in the wrong time within that period of time, if they progressively deteriorate, it's often too late to do anything. Probably the most important thing, again, for you guys to remember is you guys really control what happens to these patients. So, look carefully at the scene, examine the patient as much as you can, try to formulate in your mind what you think the patient needs, and then sell it. Just pretend like you're the best salesman at a used car lot, and you want to sell this thing, and get on the radio and sell it for all it's worth, and try to make it quick, kind of quick and sweet. This is what you think happened. This is what you want to do. If they want to ask you any questions, that's fine. But if you sell it kind of quickly like that to them, you're probably not going to get people that are questioning it too much. So again, the abdominal injuries often result in delayed recognition because it's something that develops a little slowly with time. The chest injuries often occur either dead on the scene or later. So those patients, both the abdominal and chest injuries, often are stable enough for transport, and that's something important to keep in mind. And then they afterwards become unstable, and sometimes it's just too much for a local place to handle. Pelvic fractures, you always have to think about, because they can have significant bleeding, and we don't have CT angio at Carroll Hospital Center. In fact, probably most non-academic places probably don't have those things available to them. So it's something that, to at least keep in mind. We do have some neurosurgeons, but really when you start talking about neurotrauma, in general, our patients won't be dealt with at Carroll Hospital Center. We'll have to transfer them. And the reason why is they require very special neuro-ICUs afterwards for monitoring ICP and things like that, and we just don't have those facilities. With extremity trauma, always consider the compartment syndrome or any kind of other injuries which result in loss of the limb. And probably multi-system trauma, it's just best to send them to a major center, because if we're lucky enough to get the general surgeon in, it's unlikely we'll be looking at the orthopedist at the same time, and it just really ends up being a pretty significant problem. I think that's good. So, any questions or anything?
On the bringing a patient to Carroll Hospital Center in a situation where you have a compromised airway and you just need to get that patient intubated, whether they're clenched or not, are we still looking at that 4-hour window? If I consult trauma and say, I got to swing by Carroll and I have you guys on the line, can you just get this page and tube for me so we can continue down the road? Because I know there has been an issue in the past where a patient's come in that situation and was admitted.
Right. I took care of one patient that way. It was probably about, I don't know, maybe 4 years ago or something. I think it was a maybe 20-ish-year-old guy in a motor vehicle accident that was basically racing, hit a car, and when he came in, literally there's like a divot taken out of his skull. It was unbelievable. I think we just tubed him and flew him right out. And it's basically where you're having the the state troopers notified, so they're bringing the copter out. You're basically stopping by and we're tubing them and getting them back on the thing. I mean, there might be a little delay, but it shouldn't be like that.
Okay.
I know sometimes things are a problem, but I think the best thing to do is just make it clear, I want this patient to go to shock trauma, there's an aircraft coming, and we basically just want them intubated. And it should hopefully proceed pretty reasonably. So. It's a what issue?
It's a Chicago issue or a
Impala.
Impala, thank you, Impala issue. We weren't allowed to do that.
I'm not aware of that. I mean, if that's the truth, it's something that's kind of changed, because if you got a major airway issue, I mean, basically you're probably looking at a patient that's unstable and could never be handled at Carroll because they would probably die. But in the same sense, you've got a patient you can't get an airway on that is obviously not going to let them be transporting that way. So I've never heard of that. I mean, my understanding is that it's still an acceptable thing to do. I think everybody just has to be on board with the plan. Because otherwise what happens is they come in, they get registered, we start kind of doing our process there, and it just has to be clear, look, we don't want any of that stuff. We basically just want the patient tubed, and we're just taking it with us. So, yeah.
The time we're going to have the issues with needing assistance with airway, most of your paramedics in the helicopter now are RSI trained, and that's probably the best you're going to get with
Right.
airway management. But you don't have it 100% of the time because of weather issues.
Yeah, I mean, a night like tonight, we're not going to help.
Tonight, you may have to have your hospital available to do what we need because we have no other resources, and we're going to be driving the rest of the way another 30-plus minutes of drive time. So we need an airway management during that 30, 45, whatever minutes of drive time. That's where we need your assistance, especially to RSI. I don't know what your policy is in RSI, but that's what we would want our helicopter medics to do.
Right.
So obviously, if they're not available, you're our, I wouldn't say the second, you're just next in line
Sure.
on availability. So that's where we just keep in the ambulance RSI and then continue to promote the traveling down to the trauma center.
Right. And like I said, I know it's happened at least twice. I was involved with one. I know of at least one other case. So I think as long as everybody's on board with that particular plan, then I think that's reasonable, and I can't see a reason why it wouldn't happen.
But if staff is available to do an RSI, if we would request it within, I mean, is it worth to?
I mean, we would basically have to, the physician would have to make himself obviously immediately available, and, the nurses would grab the meds and things like that, and presumably you guys would probably have a line, and at least in theory, it shouldn't be that difficult. I mean, we basically have airway boxes and med boxes. We should be able to pop them open, and if we had to, just do it like in the hallway. Like, preferentially, you'd be in one of the major rooms or something like that there. So, and they can often just move the patient out temporarily, do the rapid sequence. By then, the helicopter's there. They pick the patient up, and then the other patient goes back to the room afterwards. So,
I think that instills the thing about dual consults. Because if you do the dual consult, tell them you got an airway, give them the option, particularly if helicopters are down or they're aboard. They will tell you to go to the local. They've accepted the patient. Go to your local, get your airway, and go from there.
right.
We did have a real life situation with that here, and that's what we did, and it worked out great.
Yeah, like I said, I think as long as it's really clear to everybody involved, I don't think there's a problem. But you just want to make sure that the helicopter's on the way, or that the plan is that they're accepted already as shock trauma, and that it's basically just a temporary thing. So. And I know there's been some questions too before about like orthopedic patients being sent to being sent to Carroll. It's a difficult call. I would say a major injury in a pediatric patients probably ought to go to Hopkins. I mean, I think that's reasonably straightforward. If there's any question about neurovascular injuries, if there's a major fracture like a femur, pelvis, any kind of open fracture, because we just don't really take care of pediatrics that much except for relatively straightforward ones. The adults, and I hate to say this, but sometimes it is a little bit more time of day, whether it's the weekend or the weekday and things like that, who's particularly on call. It makes things very difficult for you guys. I think the best thing to do is just make the consult, and then we can kind of make the decision, because there may be a orthopedist in the hospital and it's not an issue at all, but that orthopedist may be an hour or two away or something like that, at a different time, where it may not be comfortable with a particular thing. So it's a difficult call, and I know it adds to a lot of frustration for you guys, and believe me, it does for us in the emergency department too. So probably the best thing to do is, obviously simple fractures are one thing, but if you're dealing with an open fracture or anything significant that you're worried about, consult us and kind of let us make that decision, and then it really falls on us. So it kind of takes you guys out of the loop. I think that's probably the best option for you. Any other questions or anything? All right.
Can we get fresh coffee in the EMS room?
You're welcome. If you guys ever have any questions, if you want to catch up with me later or in the ED or anything like that, or if there's any particular cases you want to go over, feel free to. I've had medics come to me with particular concerns about cases or questions or want to review EKGs or whatever, I'm certainly happy to do that. And if you guys have any questions too about like what happened to a particular patient of yours, you know, I'm more than happy to try to find out for you and, you know, let you know, did they stay at the hospital, did they go somewhere, did they go to surgery or not, and what kind of injuries they had. So I think it's kind of the best way for people to learn is to try to, you know, follow up as far as what happened to the patients afterwards. All right, thank you very much.
Let me have your paperwork, please.